I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound. So how do you identify dissection? So here if you start identifying structures again, this is the IVUS catheter, and then from IVUS start going backwards. This is the lumen. Around the lumen, this should be intima, going all the way around, this is intima. Then the black line all the way in between is the media, it's going all around circumferentially, and then outside the media is the adventitia. So that looks good, but if you look at the intima, it is there all the way around, but there is some flap here. So it's a break in the intimal layer, but the break is not extending into the media. This break is limited to the intima only because intima here is intact. Intima layer is intact on all four sides, 360 degrees, but there within the intima there is a break in this plaque. So this is an intimal tear or a plaque dissection involving the intima. On the other hand, if you identify here IVUS, lumen, intima, media around it, and then adventitia, and if you see this intima here, but then the media is not continuing here. In fact, this dissection has extended into the media layer. There is no intima going in front of this media layer, so intima is broken down and completely broken, and the dissection or the blood has extended into the media. So this is a dissection that is extending into media. Again, if you identify structures, lumen, that's the IVUS catheter, then the lumen, and then the intima, then media and adventitia. And if you follow this intima, it is dissected here, and the media layer has disappeared. So this media is now in contact with the lumen here up till this area. The lumen is contact, you can see here, that's the lumen, and it's in contact with the media layer here. So this is a dissection that is extending into the media. This is the right coronary artery. In the mid segment, you can see a critical disease there. It was stented, but there is some haziness here at the proximal stent edge. IVUS was done. Now this is distal and then going proximally. So this is the proximal stent edge. But as you pull your IVUS catheter more proximal, you see there is a dissection flap that is becoming visible. As you come further backwards, there is a dissection flap going like this, and this dissection is extending into the media. So this is a proximal stent edge dissection. So distal stent edge dissections are more important as compared to the proximal ones, but the ones that extend into the media are better off if we stent them. Now this is the case where primary PCI to RCA was being done. There are two separate lesions in the mid-course. One is here, the other one is here. So 2.5 by 20 millimeter balloon was used for pre-dilatation, and then a long 3.5 millimeter stent was placed and the non-compliant balloon was done. And then this is the final result, and you can see there is some problem here at the proximal stent edge. You can see this contrast line over here. So this seems like a dissection there. So we did an IVUS for this, and that's the IVUS, and that is the dissection flap that you can see here. And yeah, so this dissection was then covered with another stent because it is extending into the media. If it wasn't extending into the media, we could have stopped without stenting it. Now this is an interesting case. This is the first injection that was taken, and there was a guide catheter induced spiral dissection which went all the way into the distal RCA. So now we wired this, and then I thought I need to reconfirm that I'm in the true lumen, so I took a micro catheter all the way down into the PLV, and from there I took the injection because I could see that dissection is extending up to the distal RCA just before the carina. So over there I confirmed that I was in the true lumen. So then I wanted to start stenting. So my target was that I did not want to extend beyond the carina. So this was my target landing zone just before the carina in the distal RCA. That was the target. So I thought if I was to make a clear placement here, I need contrast injection, and I can't take more contrast injection, otherwise the dissection will extend. So I did the proximal stent first so that I could seal the entry point, and then I could safely take injections. As you can see here, I sealed the entry point, then brought in another stent and stented it as planned, covering this dissection into the distal RCA. So we covered this. The final result looks good. There you can see that's the final result, all edges covered. Unfortunately, early next morning I received a call from the on-call cardiologist that my patient had acute stent thrombosis. So they took him to the cath lab, and before I could arrive they had wired and they had established some flow, and they had done pre-dilatation with a 3.5 millimeter balloon. As you can see, patient required pacing at that time. So I wanted to know why this patient had stent thrombosis. So I did an IVUS after their ballooning I reached. So I did an IVUS study for this patient, and IVUS study was very interesting. So you can see here the IVUS catheter is here, but the stent is all the way here. So how come I'm not inside the stent? Distally I am inside the stent, but in the ostium I'm outside the stent. So the only explanation was that when they wired the RCA, they went behind and from the side struts of the RCA with the wire in, and then they took their balloon and did the ballooning. So they have crushed the ostial part of the stent, and that's what I see here. That's the IVUS catheter, that's the ostial part of the stent that is crushed. Otherwise, IVUS catheter should have been in the middle, and then it goes into the middle of the stent. So what I did next, I took a 4 millimeter non-compliant balloon, inflated it in the ostium, crushing the ostial collapsed stent properly so that it is now fully crushed, and then I took the pictures and saw that the actual reason for stent thrombosis was at the distal stent edge, where maybe I had missed the dissection, which it did not seem in the first place when we did the final image in the last intervention. But here you can see clearly that I now need to stent this. So I went on, I'm just fixing this. I've put another stent here because I now need the stent is now all fractured. I've crushed it, a part of it. So I've put in another 4 by 12 millimeter drug-eluting stent in the ostium, did ostial flaring. So after sorting this out, went ahead and stented from distal RCA into the PDA, and then the patient was fine, and I followed up this patient now for almost 4.5 years, or maybe more than that. Patient is doing well. So what's the mechanism? So usually there's a break in the intima. The orange color is the intima, yellow is the media, green is the adventitia. So break in the intima, and if there's a break in the media as well, if it extends into the media, then the blood goes and gets collected in the medial layer, and that's a hematoma that's formed here, and you can call it intramural hematoma because the media is all made up of smooth muscles. So intramural means bleeding in the muscle layer. So another image, again, if you start identifying, there is a intimal dissection here because that's the intima layer and it's dissected, and dissection is extending all the way into the media. You can see how big the media is, and then it's the adventitia outside that. So this is a CTO PCI of the right coronary artery. You can see two wires going here in the PDA and PLV, and that's the IVUS turn of the distal RCA. So you can see the IVUS catheter here, that's a second wire coming in here. This is the wire artifact. So where that second wire was coming in means this is the carina. So around that carina you can see here, that's the IVUS catheter. So now you can identify structures going from inside out or from the outside inwards, whichever is convenient for you. So if I show you the still image of this, you can now, maybe it's easier for you to identify things. So let me show you the labeling. So that's the IVUS catheter, that's the lumen, you can see intima there, and then that's the media layer, which probably seems like coming like this, and then there is also an impression of media going like this. And all of this material that you see here is actually a well organized hematoma. So this is subintimal or intramural hematoma. So this is an interesting one. If you look at this, there's IVUS catheter, there's lumen, and then the white would be intima. Then the black circumferential line is the media, and outside this is the adventitia. But if we consider it the way I've said, then what is this black line that's going in circle here all the way circumferential? Is that media? If this is media, then this is adventitia, then what is this black line? So what this is lumen, intima, this is media, but both are media because it's the inner and the outer lining of media, and rest of the media is full of organized blood. So this is not fresh blood which would appear black in the media. This is all organized hematoma within the media layer. This is adventitia. Media extends from here to here, and then this is intima. If I label this for you now, media, adventitia, this is hematoma in media. Then how do you identify thrombus? Thrombus is usually oscillating structure which is slightly non-homogeneous and it has an irregular surface. So if I identify this for you, that's media, this is the thrombus, that's the irregular surface of the thrombus, and usually it's oscillating when you pull back. So if you pull back, now this is distal going all the way proximal, you can see something hanging here, it's moving, it's hanging, then it starts increasing in size, and when you reach the point where it actually originated, you will see a stalk and the thrombus connecting to the layer of intima here. This is a vein graft PCI. Even on the vein graft you can see there is some haziness distal to the critical disease. So if you see the IVUS run, you can see this black shadowing coming in, and it's moving all the way with the IVUS catheter being pulled out. So if I show you the still image of this is more clear now, and this is a thrombus. So it's a mobile, well circumscribed echodensity. Now this is a 43-year-old gentleman who presented with NSTEMI, and during angiogram you can see there is a haziness here, probably some thrombus there. So should we stent this? How do we deal with this? Patient is on medical treatment, fresh NSTEMI. We went on to do an IVUS just to confirm what it was, and we can see a thrombus here. You can see how a tongue-like structure protrudes in and then disappears. And so that's a thrombus. There was no plaque as such that we could see. There wasn't much of a disease. So this patient probably had a plaque erosion, and on top of that this thrombus formed and caused the NSTEMI. So we managed this patient medically. 77-year-old lady underwent primary PCI from left main stem to mid LAD, and there was haziness at the distal stent edge. There, at this point there is a haziness there. So IVUS was done, and this is a very beautiful image which clearly shows this dissection and both dissection flaps there. There's a break and then it extends into the media. So if I stop this image here, you can see here that's the one end of the dissection flap, that's the other end of the dissection flap, and in between there's a continuity of lumen going into the media all the way. And if I do a chromoflow run, there you can see a chromoflow run. Chromoflow follows the blood, so you can see it very nicely going out of that opening on both sides of the media. So this is the still image to show the same. That's the intimal break here, and that's the chromoflow going like this and going on the right and on the left. Now if you follow this again, if you look at it, you will see now that you will see both the dissection flaps on both sides. And this is just in the aorta now. Once it starts running again, you will be able to see that. Okay, so now you'll be able to see the two dissection flaps. So keep looking here, and there you go. These are the two dissection flaps there, and this is the opening, and the same is shown here with the chromoflow going through it. This is the final result. Another stent was put. So this is an IVUS run after stent deployment and then post dilatation. So post dilatation, this is the proximal stent edge that you see here in the IVUS run. And on the still images you can clearly see there is a dissection flap here, and then there is blood going behind the dissection flap into the media layer. You can see it here even better. That's the media layer, thin media layer you can see there, and that's collection behind it. There's contrast and blood accumulating in the media layer. So again the same thing, that's the dissection flap that you see here and a part of it over here, and that's blood collection and some contrast collection there. So this is a 43-year-old gentleman who had 2 weeks history of inferior myocardial infarction, presented with recurrent angina, had 2 stents placed, but there was haziness distal to the stent. Now with this distal haziness, do we put in another stent or just agrastat? So we did an IVUS study for this patient, and that's the IVUS. So what you see is there is thrombus there, but no edge dissection as such. But what was also obvious was this malapposition. There was quite a lot of malapposition there. There you can see this malapposition. So malapposition is seen in the middle of the stent, and there is thrombus, but there was no stent edge dissection as such. So the malapposition was taken care of by doing post-dilatation with a non-compliant balloon, and for this distal haziness that you see here, which one would be very uncomfortable leaving at the stent outflow, but since we've done the IVUS, we are comfortable that there is no stent edge dissection, it's just thrombus hanging there. So we kept the patient on 12 hours agrastat, and the patient was discharged. So which dissections need to be covered? Dissections extending into the media, then outflow stent dissections are more important than the inflow dissections, reduction in TIMI flow, then significant intramural hematoma leading to residual lumen MLA of less than 4.5 millimeter square, longitudinal length of dissection flap more than 3 millimeter, and angle of dissection of the flap more than 60 degrees. Now this is a case that was shown in EuroPCR, but it's quite interesting, so I thought it's worth sharing with everyone. So this is a 32-year-old lady with chest pain, anterolateral STEMI on ECG, and regional wall motion abnormality confirmed on echo. Patient was taken to the cath for primary PCI, but as the angiogram was being done, the patient became pain-free, and this is the angiogram. So you can see that there is quite a lot of narrowing of the left main stem. The narrowing extends into the LAD, here it extends into the diagonal, and then there is narrowing in the circumflex, proximal circumflex as well. So there's quite a lot of narrowing everywhere. Again, if you see the image closely, so they decided to do an IVUS study of this patient. And because the concern was it could be spasm, so they gave loads of nitrates, and the morphology did not change. The other strong suspicion was that this is a young 33-year-old lady, so it could be spontaneous coronary artery dissection. So they did the IVUS study, and what they found was that this was intramural hematoma, and there was dissection here. And then from the left main stem, when they did detailed study, all the areas where the narrowing was seen extending into the LAD, into the diagonal, into the circumflex, and into the left main stem, the dissection was extending into all of these areas. So there is a small bleb type raised area which you can see here in the left main stem. So whenever you see this kind of a bleb here, you should suspect this to be the entry point for a possible dissection. So you should keep that in mind. So how was this patient managed? So this patient was medically managed, as the patient was pain-free, hemodynamically stable, there was no arrhythmia. So patient remained inpatient for 5 days, discharged on dual antiplatelet therapy, and surveillance angiography was advised. So maybe it's better not to stent these patients, because if you start stenting, you would not be able to stop. There is something called toothpaste effect. So what happens is, if you press the toothpaste, it moves forward. So the same thing can happen here in this intramural hematoma and SCAD, that once you try to do a stent, that stent may squeeze the hematoma further forwards or even backwards retrogradely. So some people stent only the entry point of dissection and leave the rest so that they close the entry point. If the patient has collagen vascular disorder and you send her for surgery, the vessel may start falling apart. It becomes a nightmare for the surgeons. OCT theoretically may increase dissection with power injector, but practically it's not documented. This is the surveillance angiogram of this patient done after 3 months. Everything has healed and the angiogram is back to normal. So ST elevation is not always an indication for intervention. Spontaneous coronary artery dissection or SCAD is more common in young females, especially around puerperium. Medical therapy remains a treatment option, especially if TB3 flow is maintained. Now, this is very important. We should not become very aggressive with this patient. Surveillance angiography can even be done with CT angiogram, and this is advised to ensure resolution. The different algorithms available to manage spontaneous coronary artery dissection, but it's important to know what are the high risk features which may force you to do an intervention. So these could be ongoing ischemia, cardiogenic shock, sustained ventricular arrhythmias, and left main dissection. And if none of these is there, you can manage the patient on medical treatment. So the different options for revascularization here you can see left main, CABG, PCI. So in PCI you can either do just the POBA plus minus stent. Some people use cutting balloon. Some people use a single long stent to cover both the edges so that it doesn't squeeze further. Then some people would stent either the proximal or the distal edge first, then come to the middle part. Some people would do proximal stent first to avoid retrograde extension or sequential stenting. So there are different ways of dealing with it.